Good evening, friends. Pradeep Pindyala, Professor of Anesthesiology. Today I am going to talk about mostly cardioversion and a bit about defibrillation. Friends, defibrillation is normally given for shockable rhythms like ventricular fibrillation or pulseless ventricular tachycardia. Here there is no synchronization for giving a shock. Sedation is just not required when you are giving defibrillation shock because the patient is unconscious in cardiac arrest. Whereas sedation will be definitely required for cardioversion if the patient is awake and it is definitely painful and uncomfortable procedure. The recommended energy for cardioversion in atrial fibrillation, atrial flutter, I would say, is 50 to 100 joules. Please call it joules, not joules. That is, if it is a biphasic. And for atrial fibrillation, it's around 120 to 200 joules if you are selecting biphasic. And for cardioversion, it's a electrical maneuver that is used for organized rhythms like unstable tachycardia, like supraventricular tachycardia, or rapid atrial fibrillation. Don't get worried, friend. I'll explain each thing very well in detail. Here in cardioversion, the timing of the shock with respect to cardiac cycle is very important to avoid R on T phenomena. The defibrillator or cardioverter has the ability to track the QRS and to stick in such a way the R on T is avoided. Now, coming to synchronized cardioversion is a procedure similar to electrical defibrillation in that a transthoracic electrical current is applied to the anterior chest wall to terminate a life-threatening or unstable tachycardic dysarrhythmia. Unlike defibrillation, which is used in cardiac arrest patients, synchronized cardioversion is performed on patients that still have a pulse but are hemodynamically unstable. It is used to treat both hemodynamically unstable ventricular as well as supraventricular rhythms. The most common cause of sudden cardiac arrest in adults is pulseless ventricular tachycardia or ventricular fibrillation. Ventricular tachycardia can also occur in the presence of a pulse. Often, it is the precursor to the ventricular fibrillation. Ventricular tachycardia is characterized by rapid, wide means always more than 0.12 seconds of QRS complexes. Supraventricular tachycardia refers to cardiac rhythm greater than 100 beats per minute, which originates above the bundle of His. Supraventricular tachycardia is characterized by rapid, narrow, the QRS complexes. Narrow means less than 0.12 seconds. Any tachycardic rhythm that does not originate in the ventricles is normally referred to as supraventricular tachycardia. And this includes sinus tachycardia, junctional tachycardia, or it could be reentrant tachycardia. Synchronized cardioversion differs from defibrillation in two aspects. The amount of energy needed to convert the rhythm is usually much less compared to defibrillation. The shock is delivered in a different part of the cardiac cycle, that is to avoid R on T. Whereas in ventricular fibrillation, defibrillation, shock is just not bothered about when you are delivering the shock. If an electrical shock is provided during the relative refractory period corresponding to the later part of the T wave, it is possible to induce ventricular fibrillation, and this is called R on T phenomena. This would result in a patient who originally had a pulse becoming pulseless and having a cardiac arrest. That's very dangerous. To perform synchronized cardioversion, the defibrillator is placed into the synchronized mode by pressing the appropriate button on the machine. This causes the monitor to track the R wave of each QRS complex and avoids R on T. The safest and easiest recommendation to start is to start with 50 joules, and if the shock is unsuccessful, double the amount of energy used. So that is how you have to do synchronized cardioversion. Well, let me explain a bit more about cardioversion. Cardioversion is the process of converting a heart that is in an abnormal and potentially dangerous rhythm into a normal sinus rhythm. The normal heart rate comes from the sinoatrial node and progresses through the right atrium to the atrioventricular node and then through the conduction system to the ventricles. I'm sure you know that. Rhythms that can be cardioverted are either atrial fibrillation or flutter or supraventricular tachycardias. Synchronized cardioversion is appropriate for all these rhythms except ventricular fibrillation or unstable or pulseless ventricular tachycardia. Electrical cardioversion can be used for patients that are hemodynamically stable as well as most likely to be successful that requires sedation. For patients that are hemodynamically stable, there are two additional options. For patients in supraventricular tachycardia, physical maneuvers that increase vagal tone can be attempted. So, what is that? Maneuver is to increase the vagal tone include having the person bear down and exhale against closed glottis. And if they are straining to have against the closed glottis, that's known as Valsalva maneuver. So, or else pressing on the carotid artery at the level of the bifurcation. Carotid sinus massage, you can do it successfully. Pharmacological cardioversion is ideal for stable patients. For those who are hemodynamically unstable, immediate electrical cardioversion is indicated. Supraventricular tachycardia is a term for a collection of clinically similar rhythms. This rhythm is defined as a regular rhythm with narrow QRS complexes and a rate that is usually greater than 150 per minute. It is treated with adenosine, which must be pushed like a bolus. The half-life of adenosine is very short and the medication is only effective if given rapidly. The initial dose is normally 6 mg IV, which may be followed with 12 mg IV if the previous one is unsuccessful. Regular wide complex tachycardia, I'm sure you would be asked about it. The treatment for the stable patient is with adenosine in the same manner as the narrow complex supraventricular tachycardia. If unsuccessful, procainamide may be used. If the duration of the rhythm is greater than 48 hours, cardioversion should not be attempted due to the fear of stroke from the left atrial thrombus. If attempting chemical cardioversion in the emergency department for atrial fibrillation, procainamide may be used, but only approximately 60% are effective. And irregular wide complex polymorphic tachycardia. This may be from atrial fibrillation combined with Wolff-Parkinson-White syndrome or atrial fibrillation with bundle branch block. I'm sure if this irregular wide complex polymorphic tachycardia, you would definitely be asked about torsades de pointes. And if the rhythm is differentiated to be Wolff-Parkinson-White syndrome. If the rhythm is determined to be torsades de pointes, the patient should be treated with infusion of IV magnesium 2 to 4 gram over 5 to 10 minutes. Patients with persistent atrial arrhythmia of more than 48 hours should be treated with anticoagulation for at least 3 weeks before pharmacological cardioversion. Also, anticoagulation should be continued for 4 weeks after the procedure, and the INR should be maintained between 2 or 3. By the way, this is also asked regarding TEE. With this, TEE is transesophageal echocardiography. It may be performed to exclude the presence of thrombus in patients with atrial arrhythmia that are considered for cardioversion. Thanks for patient listening. I'm sure it was very, very informative. And until next time, take care. Bye-bye.